Thanks, Meg. So it's my great honor to introduce our keynote speaker, Professor Mary Reilly. So it's a pretty easy job. She really needs no introduction. If you're talking about CMT, you simply say Mary, and everyone knows who you're talking about. So she received her MD from the University College Dublin, and she's now Professor of Clinical Neurology at the University College London, Queen's Square Institute of Neurology, where she leads the Peripheral Nerve Clinical and Research Group and is head of the Division of Clinical Neurology. She's been an absolute treasure to the CMT community, making contributions at every possible level. She's a truly outstanding clinician with an encyclopedic knowledge of seemingly every form of CMT. Her research contributions have been vast, including insights into mechanisms of disease, discovering new CMT genes, describing clinical features in the natural history of CMT subtypes, and developing and validating new clinical outcome assessments and biomarkers. Her group has particularly helped establish muscle MRI fat fraction as the most promising surrogate endpoint for CMT. She's been incredibly prolific with over 400 publications. So I did some number crunching, and what that means is that if you were to make reading all of her papers your full-time job, 40 hours a week, it would take you about 4 weeks to get through them all. Perhaps more important than all these contributions has been her leadership in the field of CMT and beyond. She served as the president of the Association of the British Neurologists, president of British Peripheral Nerve Society, and the president of the International Peripheral Nerve Society. She was elected a fellow of the Academy of Medical Sciences and of the European Academy of Neurology. She was also awarded the honor of the title of MBE, Member of the Most Excellent Order of the British Empire, in recognition of her outstanding service in medicine in the UK. She was a founding member and continues to be a leader of the International Inherited Neuropathy Consortium, which many of us know has been the leading driver of most research in clinical research in CMT for the past 15 years. She's also been a devoted teacher and mentor, training many of the next generation of CMT physicians and researchers. I want to make particular note of her accomplishments in her tenure as president of the PNS and her contributions to the INC. As PNS president, she established the junior board as well as the pre-meeting teaching course, which has been one of the most popular elements of the annual meeting at the PNS. In the INC, she developed the International INC Fellowship Program, which provides 1 to 2 years of training support for early-stage CMT researchers. This program has been instrumental in training and supporting many of the current and future leaders in CMT. And as a former recipient of this fellowship, I can say that it was really critical in my own path to developing a career in CMT. In Mary's remarkable career, she's contributed so much to the field, and we're truly lucky to have her. So with many clinical trials either underway or on the horizon, we're at an exciting time in CMT research. It's also a time that brings major challenges and major risks. To finally deliver effective treatments for CMT, we need a coordinated, collaborative, and integrated effort from clinicians, scientists, industry partners, regulatory agencies, patients, advocacy groups, and of course, patients themselves. And I can think of no one who better represents and embodies this collaborative spirit than Mary. So with that, please join me in welcoming Mary Reilly.
Thank you very much. Is the clicker? Oh, thank you very much. Thank you for that amazing introduction, and thank you very much for the organisers for inviting me to speak today. So I'm going to talk about strategic considerations in the development of CMT therapy. These are my disclosures. And when I think of developing therapies, I think of a circle of translation. You start with the patient. You first of all have to find out the causative gene. You then move into the preclinical field where you try to work out how that gene causes the disease. This hopefully leads to candidate therapies, which are taken into preclinical trials, clinical trials, and then back to treatment for the patient. So that's what I call the circle of translation. Now, unfortunately, in CMT, we've done extremely well at this end. We've over 130 causative genes, but as of yet, we've no effective treatment for any form of CMT. I'm going to dwell on a number of areas today, talking about strategic considerations highlighted above, but I'm not going to talk very much about the preclinical, which has been covered beautifully yesterday by many people and again will be covered today. So starting with the patient, it's all about the patient. And I would argue to actually treat CMT, you have to understand the phenotype in huge detail. So we think of neuropathies as either being a pure neuropathy, which people often think of CMT as that, or a more complex neuropathy. And straightforward CMT is a lent-dependent motor and sensory neuropathy. But we do know that there are pure motor forms, hereditary motor neuropathy, and pure sensory. So it's a continuum from motor to motor predominant, to motor and sensory, to sensory predominant, and to pure sensory. And the reason this is all one family is the causative genes for the dominant and the recessive forms overlap in phenotypes. So when I talk about CMT, I talk about this whole family. But we know within the family, there's already marked variability in the phenotype. So we have the traditional classical lent-dependent type. We have this patient with a BSCL2 mutation presenting in his hands, this patient with a sigma-1 mutation presenting with wrist problems. And this poor patient at 18 has congenital insensitivity to pain, a severe sensory neuropathy. He had bitten his tongue while teething as a child. And by 18, he had above elbow amputation and 2 Charcot joints. So even within the family of CMT, there's a huge diversity of phenotype. Now, saying that, most forms, and particularly the common forms, are lent-dependent. And that's actually really important for us thinking of strategic considerations because it helps us develop the outcome measures to actually do clinical trials. And outcome measures that can be used across clinical trials are very attractive. And this, of course, is what CMT lent-dependent looks like. This is one of my patients with X-linked CMT. You can see the wasting in the lower limbs and the classical foot drop of CMT due to ankle dorsiflexion weakness. But we do know there are complex neuropathies where CMT or with inherited neuropathy is associated sometimes with ataxias, such as spinocerebellar ataxias, or with spasticity. And sometimes this looks like CMT and then something emerges or a brain scan is done. And we still call it CMT, but is it CMT? And if we think about some of the genes, particularly those involved in the axonal forms, in the cell body and the axon, the vast majority of these proteins are ubiquitously expressed. And one of the questions is, why do ubiquitously expressed proteins cause just a neuropathy? And people argue maybe it's the length of them, maybe it's axonal transport. And that may be true, but do they just cause a neuropathy? We know with myodiffusion, you can have optic atrophy, you can have CNS disease. We know with the X-linked form, due to JGB1 mutations, you can get white matter disease, particularly in young men and in late boys, teenagers. And we know with the small chaperones, HSPB1, B8, BAG3, you can get a myofibrillar myopathy and cardiomyopathy. And why do I dwell on these minor variations from neuropathy? Well, because of this study, among others. So when you develop treatments, sometimes things happen that make you rethink. So in this open label gene replacement trial in myotubular myopathy, patients did well on the outcome measures, but 4 patients died because of, 4 patients died because of cholestatic liver disease. And it emerges that there may have been an underlying liver abnormality that wasn't known about. So when we're thinking of developed treatments for CMT, we need to understand the phenotype, particularly for the axonal type. What do these proteins do that we're not seeing clinically? We also need to think of the lifespan. We live a long time, and that is good, but it may mean the proteins do different things along our lifespan. So you can imagine some proteins being really important in development. Then in those teenage years where some people, not all of us, grow up to 6'5", they have to work really hard. And then maybe in older life, they're involved in maintenance. So it may be that the protein's function may vary during their lifespan. And even for the same gene, we may have different treatments depending at what point we are treating. So when we're thinking of the phenotype, we need to see, is it lent-dependent or not? Because that will help us design trials. Is it neuropathy, or is it neuropathy plus with some subclinical stuff we're not seeing? And when are we aiming at treating? Are we aiming at treating in childhood, adulthood, or both? And will it be the same treatment? So that to me is critical in developing clinical trials. And we need to remember the humans are the ultimate animal models. Of course, all kinds of models are important, but there are certain questions we will only answer in studying humans. And every time we do a trial, it is also a study. So the second area is genetics. Now, we've done very well in that. This is my group's paper from last year, where over 1,700 patients, the diagnostic rate is 77%. So the vast majority of patients get a genetic diagnosis. We are much better at CMT1 with about a 97% versus the axonal forms, which is about 50%. So there's still something that's quite tricky in finding those genes. But if we look at them, there are some genes that are relatively common. And if you look at the top genes here, they account for 72% of all of the rest. And that's good. But it also means we have a huge number of forms of CMT that are very rare. And we'll have to think about that when we come to doing clinical trials. Now, these are the patients that I have unsolved in my cohort. And as you will see, if you look at these, the vast majority of them are axonal, motor axonal, either CMT2 or HMN. And that will be the same in most groups. And of course, the advent of next generation sequencing, long range sequencing means we'll find new genes, we'll find non-coding variants, we'll find structural variants, we'll find expansions. But I think there's a whole new area of genetics which we're only beginning of. And that's what I call the modifier. So there will be genes that actually modify the gene itself, genetic modifiers. There are genes that will modify the phenotype, and we don't understand the phenotype variability with the same genes, even within families. There will unquestionably be drug response modifiers, and we know that from, say, azathioprine as an immunosuppressive, etc. But I think there'll be side effect modifiers. There'll be genetic variations that tell us what side effects people might get. And I think a whole area that will be phenomenally important for gene therapies will be the immune system. What are the genetics of our innate immune system? How will an individual person respond to gene therapies that have an immune attack on the system in some ways? So that's a completely new area for CMT, although it has been looked at to some extent in other diseases. But the biggest challenge right now is the variants of unknown significance. Now, many patients get a report that say it's a variant of unknown significance. And you may think, well, so what? We think it's pathogenic. When a clinical trial comes, you'll only get into it if it's likely pathogenic or pathogenic. So we do need to solve this problem. And people use the American Society of Human Genetics, which is a very good way that combines segregation, population data, functional data, etc. And we've published our really interpretation of that, making it all a little bit easier. But when you look at it in detail, and this is some of the work we've done as part of the INC, it's 2 studies we led on 2A and 1X. And as you can see, we can get it up to 87% of likely pathogenic or pathogenic in CMT2A. And in X-linked, we can get it up to 82%, whereas ClinVar is 74%. So by doing detailed studies, you can push it up, usually by segregation in families. And in my experience, over many years, doing both research and diagnostic laboratory work and the clinical work, is the strongest proof is multiple families with good segregation. That's the strongest proof. I know there's a lot of functional scientists, but it is the strongest proof. And AI tools are increasingly helpful, it has to be said. And I think, many labs around the world, we all do multiple diagnostic tests and nothing ever gets reported centrally because you don't need to do it. I'm very pleased to say the UK made the decision this year that all diagnostic labs have to upload all mutations to ClinVar. I think that will help. If everybody was doing that, it would increase this problem we have with VUSs. And I'd like to point out this paper of Brett's, and I think this is what needs to happen before a clinical trial. So Brett and colleagues are working towards a clinical trial in TRPV4 related CMT. So they did a nice natural history study, and what they've done is come up with, I think, a really excellent algorithm using clinical segregation and relatively simple functional tools, so they will know that the patient has a likely pathogenic or pathogenic variant before they do the trial. And this is going to be critical with any clinical trial for any form of CMT, other than CMT1A, which actually is one of the easier ones because we know it's pathogenic. So moving on to clinical trials. So we are having the conversation about clinical trials because we're in a really good place in CMT. So this is a paper from a review paper from David Parison recently, and this shows you most of the treatments that either are in trial, being developed, many of them preclinically, but it's a very exciting area. I have a relatively simplistic view of treatments. So you move from DNA to RNA to the protein. So traditionally people did pathogenetic research. So we used to find the gene, find the protein, and then much research into how the protein causes the disease. And that's tough. And actually, it hasn't delivered hugely yet, although there are promising things coming. But that's across neurogenetics. Of course, the game changer is when we develop what we would call gene therapies. So this includes ASOs, siRNAs at the mRNA level, gene replacement therapies, editing, CRISPR-Cas9 at the DNA level. And these have revolutionized medicine because they're disease agnostic. in terms of developing it. And then, of course, what we really love is pathway therapies. Imagine a drug that treats axonal damage that you can give to patients prior to chemotherapy, that you can prevent diabetic neuropathy. So people have always wanted to get some sort of pathway therapies, and that's still a really important part. And it is likely that if someone is standing here in X number of years' time, people will be on combination therapies of a specific therapy for the gene, but something to help axonal transport or whatever else needs to be helped along the way. So just to give you examples of these, I'm not being comprehensive, just examples. So the SORD neuropathy is a great example of a pathogenesis story. This is a gene that was only described in 2019, and this is work led by Stefan Zuckner, and the first author is Andrea Cortesi, who's doing a postdoc with me and then with Stefan. And this is a classic form of CMT, where you have biallelic variants in sorbitol dehydrogenase, which causes an increase in sorbitol, which has been shown to cause the neuropathy. There were some drugs available, that aldose reductase inhibitors, that allowed it to be shown in principle in preclinical models that if you reduce sorbitol, this could help the neuropathy. And this has led to a company, Applied Therapeutics, who had a novel aldose reductase inhibitor take it to clinical trial in 2022. And I'll come back to that, but that's a classical pathogenesis therapy. In terms of the gene therapies, of course, the disease I think is the best example in neuropathy is TTR amyloidosis. Now, this is an easy disease to treat in that 85% of TTR is produced in the liver, and you don't actually need that TTR. So you can gene silence it without doing allele-specific gene silencing. So this has led to a revolution in treatments. So we have ASOs, siRNAs, and we're at the third generation in trials of siRNAs, and we have second generation ASOs and siRNAs available, and there's an ongoing trial of CRISPR-Cas9. So that, for me, as certainly in my practice, patients used to die on average 4 to 5 years because they also had cardiac involvement. It has completely changed my practice, having to open new clinics to deal with patients who luckily are alive. So that's a really good story. It's simpler to treat because of the liver, but it's a good story. And of course, in the CMT world, this is another review by Cleopas, just highlighting where we are. And you've heard about some of these. You've heard about the IGH and PB2 clinical trial yesterday. You've heard about the proposed trial for FIG4. And many of these, particularly the double asterisks, are now in non-human primates. So a very exciting world out there, and a lot of them for gene replacement in the recessive ones in X-linked CMT. And finally, the pathway therapies, you've heard about these, as I said, ones that could actually deal with more than one type of CMT. And there is an ongoing trial of a calcium inhibitor, which, because the neuromuscular junction has been shown to be important in animal models and in humans, may improve muscle function, and there's a synapse trial that's happening in Europe and the US. And you've heard about the HDAC6 inhibitor story, and you've heard about the SARM1. And these are not in clinical trials yet, but we hear the HDAC inhibitor is going into phase 1 trials. So this is all very exciting in terms of pathway therapies. But what are the challenges? So I think the first challenge is preclinical validation. And even though I said I wouldn't talk about it, I'm going to make one comment. So as a person that does genetic research and mainly clinical research, but yet we're the people taking things to clinical trials, it is still a problem for us that there's no gold standard published of what we should expect. How many trials should be done in animal models? Should it be more than one? Should it be mouse and rat, or should it be 2 mice? How many animals are needed in a clinical trial? What backcross is used? What outcome measures used? Does it have to be a combination of histology, nerve conduction studies, and behavior? So when we're accessing and we're looking at them to see, can we take it and is the science good? I think as a group and as a field, we do need some guidance on what best practice is. And I know the basic scientists here think I know what best practice is, but I don't. So every time I look at a paper, I'm thinking, was that number of mice enough? Was it not enough? Are those nerve conductions really convincing? So I do think that would be helpful. You've heard a huge amount about the challenge of delivery systems, and I agree with whoever said yesterday, it's all about delivery, delivery, delivery. And luckily, there's a huge amount of people in the world working on delivery, 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 because it's such an important point. And the blood-nerve barrier has been mentioned because people forget that, certainly in neurogenetics when they're talking about the central nervous system. And we've heard the arguments and we've heard examples of the vast majority of above. I'm just going to mention one thing that we can't really deal with yet, and that is the bottom one. So we know that when we do the non-human primates, they are healthy animals. So we're looking for distribution. We talk about distal distribution, proximal distribution, if you give it intrathecal, if you give it systemically. But we will not know, will delivery to CMT nerves differ from normal nerves? So having looked at multiple biopsies in patients over the years, a CMT nerve, if you take a distal sural nerve biopsy, I mean, the nerve is destroyed, and what will delivery to these nerves? So it may be, so we know there's some very good nerves still there. Maybe the proximal delivery is what we're actually aiming at, even in the lent-dependent neuropathies. So we won't know do this until we do the trials in humans. So there's certain questions that we'll only answer when we get to clinical trials. So that's why continuing to research everything we do in every clinical trial is incredibly important. Most forms of CMT are slowly progressive. Now, patients, when they come to clinic and I will say, how do you think you are? They'll say, I'm a little worse than last year or a little worse than 2 years ago. And I'll examine them and things are the same with our blunt instruments. And I'll say, I know you feel a little worse. It's our instruments that are the problem. But they are slowly progressive, and that's a problem for clinical trials. But more importantly, the safety barrier for treating most forms of CMT, particularly CMT1A, where life expectancy is not compromised, has to be really high. We cannot do it until it's safe enough. And this is different from some of the other diseases like the TTR amyloidosis I've mentioned. Most forms are rare. I've said 6 or 7 are commoner, but most forms are rare. So the challenging trial design, it'll have to be different. There'll be N is equal to 1 trials. There'll be different ways of doing trials, and we have to embrace that like we're doing for many other neurogenetic conditions. And of course, one of the big areas is how we do outcome measures in clinical trials, how we prove something works, particularly for the commoner types when we'll be expected to do placebo-controlled trials. So CMT1A is the commonest type of CMT, and in a typical US and Northern European population, it's about 50% of patients. It is a slowly progressive condition that starts in the first decade and causes a lot of morbidity over life, particularly because of the unequal weakness in the feet, giving you foot deformity. And I have had patients had between 10 and 20 operations, and each operation takes 6 months out of your life to just accommodate to. So this is quite a high morbidity disease, but it is slowly progressive. And we've been thinking about this for some years, and what I'm going to mention this one slide on statistics, which is the standardized response mean, and that is the mean change divided by the standard deviation of the change. So simply put, we want something that changes enough in 1 to 2 years that we can do a clinical trial in a relatively small amount of patients. If it changes too little, it will take too long and will need too many patients. So we've started thinking about this as a community for years, and this is the first measure we developed, the CMT neuropathy score, in 2005, which is a combination of symptoms, signs, and neurophysiology. And this has become the standard to describe CMT, and it's very, very good at delineating severity. But in clinical trials, and this was the original UK-Italian vitamin C trial, it didn't change over 2 years. So we tried to improve it, we tried to improve the sensory component, we rash modified it, and we use it without neurophysiology. We call it the CMT examination score. And that allowed us, as part of the Inherited Neuropathy Consortium, which Brett has mentioned, which is an NIH-funded consortium for 15 years and recently has been now funded by CMTA going forward. And this has allowed us to do up to 8 years longitudinal studies in all the common forms of CMT, 1A, 2A, SH3TC2, 1X, and 1B. So we have data on all of these. And the first thing I'll say for my patients with CMT1A, because sometimes they get very frustrated at being told there's no change. It does progress, but it progresses slowly. This is 6 years to go up 2 points on the scale. So it is progressive, but it's slow. And it has allowed us, using these large natural history studies, to develop SRMs in each form of CMT, as you can see here. Now, what we're looking for in the standardized response mean, we're aiming at large. We're aiming at 0.8 or near 0.8 to be able to do a clinical trial with reasonable numbers. That's what we're aiming for. And as you will see, we've not gotten near there in any of these using the clinical measure. The best one is CMT2A, which just gets into moderate. So we've known for a while that it's going to be difficult to do clinical trials using these clinical outcome measures. Now, we have developed the pediatric score, which again gives you a lowish SRM, but not bad. We have an infant score. And recently, David Herman developed the CMT FOM, which is a functional outcome measure, which tries to look a little bit more of the function of the patient. And it's a little bit like the PED score. Now, this hasn't been published yet, but we have presented the data from this. And this is the 2-year data. And the 2-year data again shows that the CMT form, like the CMT-ES, like the ONLS, do not progress over 2 years. So they're not sensitive enough to pick up change in a short period of time. So we've been thinking about this, and I've been concerned about this, and this was a review we did 5 years ago, just saying what's out there is not sensitive enough to do clinical trials. And, partially related to being frustrated, we wrote another kind of an opinion piece a few years ago saying that in slowly progressive neurogenetic conditions, that is CMT, HSP, ataxia, etc., we do need to move towards thinking of surrogate endpoints or biomarkers, particularly for the early stage trials. And the reason for this is the following. What we absolutely do not want is clinical trials over 1 to 2 years done with clinical outcome measures that will not give the answer. That is a waste of patients' time. It's a waste of our time, and it's a waste of money. And we don't want really long trials. We know trying to keep people in clinical trials for over 3 years is quite tricky. It is difficult. People have lives to lead. Things happen. They get pregnant. They have some foot surgery. They just cannot commit to clinical trials for that long. What we want is we want biomarkers of target engagement. We want to know we're in the right place as early as we can. We then want bridgeable biomarkers of treatment response. We want biomarkers that change in a couple of years, but that predict clinical progression over 5 or 6 years. And these bridgeable biomarkers can be called surrogate endpoints. Now, we have some biomarkers of target engagement. The PMP22 levels are a great biomarker for CMT1A. The sorbitol levels are a great biomarker in SORD neuropathy. And in a small trial, I'm doing an investigator-led trial, the deoxysphingolipid levels are an excellent biomarker. So in certain forms of CMT, we have those biomarkers. And that'll be important for every trial of CMT, if possible, to find some sort of target engagement. But the biomarkers of treatment response are more challenging. Now, clearly, the most attractive is a blood biomarker. So it is the most attractive. And I have to say there's been a huge development in the ability to develop ultra-sensitive biomarkers of recent years. So we started thinking about this some years ago, and like almost everyone else in the field, neurofilament is the most attractive because it's a major part of axons in the peripheral nervous system and central nervous system. And our initial study in 2018 did show that in CMT overall, neurofilament is increased compared to controls, but there was overlap, and that it did correlate with clinical outcome measures. But when we looked at it over 6 years, it remained stable. And that's not a surprise in CMT1A because you have a constant, very slow rate of axonal damage. So if the aim of a treatment was prevent progression, we would worry that it's unlikely you'd pick this up. But we don't know, because if you look at something like TTR amyloidosis, when we looked at that some years ago, we again noticed that the neurofilament was increased in patients with TTR compared to controls and with those with neuropathy compared to cardiomyopathy. We saw that. And then in the clinical trials, it was very responsive. So if you look at the patients who were on the drug versus placebo, the neurofilament dropped. So it may be in some forms of CMT that we may see it, but we worry that we won't necessarily see it in some form. So I certainly would always include this as a secondary outcome measure because we just don't know till we have a treatment that works. Then John Savran has developed transmembrane protease serine 5, which seems to be a specific biomarker for CMT1A. And this currently is undergoing longitudinal studies with many of us involved to look at it longitudinally and compare it to our other biomarkers. Similarly, John has looked at muscle and Schwann cell-associated microRNAs. Rita Horvath's group has looked at NICAM1 and GDF15 across a wide range of CMT, and again, these need longitudinal studies. And recently, we have been working together with Mike Lunn and Roberto Ballanti on periaxin. Now, this isn't published, but we have presented some of this data. And in plasma, we looked again at neurofilament, which is increased in the common types of CMT compared to controls. But interestingly and predictably, the periaxin is increased more in CMT1A and CMTX1 versus 2A, but all are increased compared to controls. So we're now studying this in a much larger group of patients because we've shown in inflammatory neuropathies that this can predict people who are about to relapse. So it seems to be quite a good biomarker, but it's early days. So all of these blood biomarkers are hopeful, but we do need to see, will they be sensitive over time? And can we do it even more sensitive? So I think it's an interesting area. I'd always include them, but there isn't one yet that we would say, that we could say. People come to us and say, can you give us something that will show response in 6 months? Well, no, not yet. Now, I've had an interest since 2009 in imaging biomarkers. And I want to particularly mention the MRC who funded this work for about 15 years, and then MDA have funded, and CMTA and MDUK. So this is work, and I want to mention 4 people that have worked with me doing this. So we have Jasper Morrow, who now runs the Neuromuscular program, who is a PhD student, Matt Evans, who's in Australia, who's a PhD student, Carolyn Dorothy, who's moved to Glasgow, and the most recent Luca Don. They've all worked on this. And this is based on, if you denervate muscle, you get fat accumulation. So in this cross-sectional study, this patient has very little fat, 1.1%, and is very mildly affected. This 37-year-old man has a little bit more weakness and has got 5.8% fat. But this woman at 53 has severe CMT and 81.7% fat. Now, I want you to look at this. This tells us we have to treat early. Once you've that much fat in the muscle, you're not going to retrieve that. So we know we need to treat early in all forms of CMT. So we decided to see, could we measure fat progression over 12 months? And our first study in 2016 looked at 20 patients with CMT1A. And we did show just over 1% of fat progression a year. And we were able to have an SRM of 0.83, which was a large responsiveness. I have to say, I was a bit surprised at this. It was better than I expected. So then we did the same study in another scanner. So we did it in Iowa with Mike Chai. He did the scans. We set them up to do them. We improved the positioning, and then we did all the analysis in London. And again, got excellent results with an even better SRM. We did find out that when we looked in detail, we could enrich a population. So if we looked at patients who had more than 10% fat at baseline, we were getting to the stage where we could do trials in very small numbers of patients. And since then, last year, a French group produced the same results in a study, again looking at fat, again about 1.3%. So that's multiple studies showing in CMT1A, you can show progression over 1 year looking at fat fraction. We now are part of what's called the ACT-CMT study, which is a study that David Herman is running to look at outcome measures, particularly CMT-FOM. And we've done a sub-study in that, where we've looked at 67 CMT patients and 25 controls. Now, we did this to look internationally. There's 3 US centers, 1 UK center, that's us and Milan. And we've looked at all of the scanners. So we've shown we can introduce this easily in scanners and do a study with a central analysis. And again, over 2 years, we're getting the same percentage increase in fat per year with the same SRMs. So that's very encouraging data. But I've stressed we need to treat early, and those of you will have spotted the number of patients that have less than 10% fat. So we need to be able to do something for those. So what did we do? Well, we thought this is a length-dependent neuropathy. We already knew if you've got a huge amount of fat in your calf, it can move to the thigh. So we thought, can we go more distally? So we developed a muscle MRI fat fraction protocol for feet. And this is someone normal, and this is someone with CMT1A. And we did a study in children from age 5, and age 5 is as young as you can get a child to have an MRI without an anesthetic. So that's why I picked age 5. So age 5 to 21, and showed again, we can actually measure fat fraction, getting an excellent SRM. And just to look at that, this is someone with normal feet and a normal calf. This is someone with 1.2% fat in their calf, but they have 20.2% fat in their foot. And this is someone who still is only 2.3% fat in their calf, but they've almost 50% fat in their feet. And anyone with CMT will not be surprised at that. It is feet first. Then we thought, well, would this be useful over all kinds of CMT that are length dependent? So we took the next 3 commonest forms of CMT, that is JGB1, myeloffusion, and MP0, and did a 12-month study. And again, we showed that the fat fraction correlated with all our clinical markers and with neurofilament light chain. And again, these are just examples of M1X, 1B, and 2A, which, as you can see, is much more severe and also has a lot of fat infiltration in the thigh. And again, we showed at over a year, they're all responsive, and actually CMT2A is also responsive in the thigh. But will it be useful in clinical trials? Is this just a nice measure? So to be useful in clinical trials, it needs to be pretty well and easy to do. So one of the things that was taking us a huge amount of time was actually drawing these things called regions of interest. So there would be a fellow sitting down, drawing these regions of interest. So we fed all our data and developed an AI program, which we called Muscle Sense. And then we did another 12-month study. And this 12-month study is comparing our AI program against us. And as you'll see, the AI program is excellent. So we now use our AI program with quality control to do all of our fat fraction analysis. And the second critical question is, will it be useful in clinical trials, is does it predict clinical change? And we've got some pilot data for that. So in the original study we did in 2016, we got the opportunity of following people up for 4 years. Not everyone, because people do fall out if you do a long study. So out of the 20 original patients, we had 9 follow-up. So it is small numbers, but we did show that the percentage of fat fraction increases and correlates with clinical measures. And more importantly, change in fat fraction in 1 year predicts clinical change over 4 years. We are now looking at that in the ACT-CMT study. So we have the 2-year MRI data, and the CMTA have funded a further 2 years on top of the 3 years, so we can really compare this to the clinical measures over 5 years. So that's going to be a very important piece of work. But is it being used in clinical trials? So the lovely thing about doing a clinical investigator-led trial is you can pick your outcome measure. So there's a very rare form of CMT called hereditary sensory neuropathy type 1 due to serine palmitase transferrin long chain subunit 1 mutations. So it's a very rare form of CMT. And I wanted to do a clinical trial on it. There's only about 50 patients available, so it's very rare. And I won't go into the details of how we did this trial. But we needed an outcome measure that would let every patient be involved. And we did a 1-year natural history, and our MRI was the best data for this, even though it's a neuropathy that starts clinically. So we've developed this outcome measure where everybody at baseline gets thigh, calf, and foot, and at the 1 year. And then we go back and we look at the baseline. And those patients between 5 and 70% in the calf, we use that as the primary outcome measure. More than 50%, we use the thigh. Less than 5%, we go down to the foot. And we call this the severity appropriate. And this is being done also with FSH. And this may be important for very rare forms of CMT to allow you to enroll everybody regardless of their severity. And I just wanted to mention the SWORD study because that's the second study that is using it. So the SWORD study planned a 2-year study, but it already had planned an interim analysis of 12 months to look at the level of reduction of sorbitol. And the sorbitol did reduce, and there was some correlation with reduction in clinical measures, although none of those were significant. So they stopped the trial at 12 months and put everyone on an open label extension. Now, because the trial was stopped, some people had had the 24-month, but not everyone. So the MRI of placebo versus the aldose reductase inhibitor showed no change at 12 months. Now, there were only 13 patients who had data at 24 months. And of those 13 patients, 10 of them were on the drug and 3 were on placebo. And the 10 on the drug all showed a slowing of progression versus themselves and also versus the whole group. Now, that's tiny numbers. I know that, and it's a pity we don't have more numbers, but this is an example. This is someone who progressed their thigh and their calf over the first 12 months, and then it stabilized. And that may tell us that maybe if you stop a nerve causing damage, it takes 12 to 24 months to begin to see the fat progression slowing. We don't know that. We don't know if this is a real result, so we get more data. And we don't know whether it just applied to this one, but it's our first hint of the timing of what we will be able to see the change fat fraction. And they now are going to do a longer 3-year study, and in that they will have MRI of a secondary outcome measure. MRI is not going to be accepted at the moment as a primary outcome measure by the FDA, EMA, or MHRA. So to kind of summarize about muscle fat fraction, it is the most responsive outcome measure in CMT to date. It can be done in all types of scanners and easily implemented in international setting. And scanners are very common in many centres. It correlates with clinical measures at baseline in repeated studies. Our pilot data suggests it predicts clinical progression and therefore could be a bridgeable biomarker. There's ongoing studies to validate that. And the critical question is, how long will it take it to stop progressing in a clinical trial? It looks like it's going to be much quicker than clinical measures from our natural history data, but we won't know this till we have a trial that's worked so we can actually say that. So what I'm doing going forward in this area, I have a new study started funded by Muscular Dystrophy UK to try to just make it even better. So we're developing what we call the AAA MRI protocol, which is an advanced AI accelerated. So we've got more sensitive ways of doing fat fraction than we had using the 3-point Dixon in 2016. We're getting the protocol down to 30 minutes to make it easier to do in clinical trials. And we're optimizing the whole processing to make it completely AI rather than just the segregation. And we're going to make sure we do this across all the scanners, so it's something that can be used across all scanners at any one time. We've also set up 7 sites in the UK to do this, so the UK is trial ready with multiple centres with it all already set up in it. So are we ready for clinical trials in CMT? Well, I would say we are. There's been huge progress in the last decade. There are trials ongoing, as you've heard. Drug delivery systems is the biggest challenge, and I'm delighted so many people are working on that, because that is something that will be overcome. I've no doubt about that, but it is important. And I think, as I said earlier, thinking of what bit of the nerve, proximal versus distal, might help us decide where we should be aiming at. The outcome measures and biomarker world is absolutely critical for each type. And I would suggest anybody designing a trial needs to start thinking of a target engagement biomarker from the beginning. Natural history studies are absolutely critical. And I would say the BRETS 1 and TRPV4 is really important. It's really worth the money and the time. You've got to do them to know what to do. And they can be run in for trials in very rare types. And you will need bespoke trial design for the rarer types. There's no such thing as something is too rare to do a clinical trial in. That's just the challenge for us to do that. So I've said natural history studies are critical. And I'd like to stress that once we have treatments, and we know this from TTR, from Duchenne's, from SMA, that is the beginning of the journey of the continuous cycle of translation. And we have an opportunity in CMT now that every patient that goes into a clinical trial can be followed up for the benefit of the whole field. So we begin to see what works. And if we don't do that, it is something that would be pretty unforgivable. I think that's really, really important. I hope I've given you a flavour of what I think are some of the high-level strategic considerations for CMT. And I'd like to finish by saying I never want to show this slide again. I very much hope the zero will disappear very, very soon. And finally, to thank, this is my inherited neuropathy group in Queen Square, and the physicists and the computer scientists will never get into a photograph. That's why they've been photographed in there. They just will not come down to be photographed. They just stay behind the scenes. But obviously, I've mentioned quite a lot of people here who've been pivotal in all of this work. And finally, of course, no work can happen without the funders. And I particularly am grateful for the ongoing funding we've had from this. Thank you very much.
Hi, Mary. Mary online. Hello? To your right. Hello.
Right. Okay, right. The whole way over there.
Sorry. Fantastic talk, Mary. I have two questions here online. What can you say about the changes in nerve conduction studies, and are they not helpful for looking at the disease progression in CMT patients, especially for translating therapies? And then another one is about the fat fraction levels for patients who are being followed up. Are they not supposed to be working out, or does any exercise have implications on that?
So the first one first. So we know that nerve conductions are very good, both the velocities and the amplitudes, in terms of telling us what type of CMT is. But we know from multiple studies that over time, they just don't change fast enough. And there's just variability between them. So they're useful, but not in the short term. Conduction velocities in CMT1A, we know that disabilities are related to the axonal damage. I suppose we just don't know. If you treat children early, I would say that there may be room for conduction velocities improving, but we don't know that with treatment. So I would say they have to be in every trial, but there's no evidence yet they'll be sensitive enough to pick up change. The second one, what I didn't put up here, we did 10 years of MRI work in advance. So we looked at fat, we looked at exercise, we looked at age, we looked at males, we looked at females, we looked at every variable and allowed for all of those. So you can work hard, do what you want, it doesn't affect it. So we've done all of that work and we've allowed for that in all our analysis.
Mary, this is Carlos from the TVS. I have a question about the translational predictability of the biomarkers that you just mentioned for drug discovery.
Sorry?
For drug discovery. So let's start with the fat fraction MRI. Like, have you seen this particular biomarker, be, at least validated in some preclinical models of CMT, and that would you recommend it being used for drug discovery and development?
Yeah, that's a very good question, and we can do it in animal models. It's we have an MRI scanner for our animal models, and you can do it. It's pretty expensive, and it's pretty it's pretty challenging to justify it in multiple things. I don't feel we need it to translate it. I think there are enough other markers of success of a treatment in animal models that we actually don't need it, as long as we have shown that in humans it predicts clinical change and it matters to everything. So I don't feel we needed to translate it over as a biomarker.
Okay, great. And so the follow-up to that is, when we're thinking about those translational biomarkers that we want to see change in a preclinical model that we can use for, dose discovery preclinically, which ones do you think are the best validated or the most promising right now, or let's say CMT1A, as you mentioned?
Well, I think CMT1, I'm glad you asked me that one because it's an easier answer. I mean, I think, most attempts at the moment to treat CMT1A are reduction of PMP22. Not all of them. I know there are other ways. And of course, that would be the biomarker to translate that as a biomarker. I mean, clearly, I feel Steve Scher in the room, even though he's gone, saying you want your animal model with behavioral nerve conduction studies and particularly histology, if I'm quoting Steve in it. But I would say PMP22, the downregulator, done very accurately. I mean, there's better ways of doing it now. And there is work ongoing to see, can you do it in blood rather than just do it in skin? At the moment, it has to be done in skin. So that would be the top one. I think for all other forms, I think it is a matter of finding one that is as specific as possible to your gene, but also one that translates across them. I think neurofilament is still a very good one. There's been success with neurofilament in multiple animal models of CMT, but not in human natural history, but that's different. So I think neurofilament I certainly would use.
Okay, so as a surrogate biomarker, you would say neurofilament, and potentially, are there others that you think are also promising? We've heard about acetylated tubulin and others. Would you also think about those?
So I think there are many other ones promising, and we just await the great data that I hope will be presented on them. So I think I do think the way we can do much more sensitive assays of biomarkers, particularly in serum and plasma, is hopeful for the future.
Over here. Okay. So we have a variety now of different biomarkers that we can look at: muscle fat fraction, levels of neurofilament in plasma, the neurology scores. I'm wondering if anybody has tried to combine all of these and give them like a weighted score. And now there's the wearable sensors too. So rather than relying on one or two, is if we actually use a computational model and build all of these into one score.
So I think it's an interesting concept, but if I go back to the CMT neuropathy score, which already has symptoms, signs, and neurophysiology, one of the complaints about it is a composite score. So I would say the regulators generally, we have found, don't like composite scores in these diseases. And if they don't like composite scores, simple ones like that, to add in fat fraction, biomarkers, etc., I think will be quite challenging. I think they want a cleaner output than the composite scores. That's our experience. I think it's just too complex to put all of it together. I think wearable sensors, to me, are very promising. I doubt, again, they'll be sensitive enough in a very short period of 1 to 2 years, but I think they could be very sensitive for predicting, can something be a bridgeable biomarker? So I think one of the problems is there's so many patients with CMT have so many things going on that affect their mobility. Fatigue is a huge part of CMT for a lot of patients, and your variability day by what you do, which makes me worry that doing the clinical alone will never be enough. I think generally people don't like, we find regulators, big composite biomarkers. And certainly there's a pushback every time that I've been involved with discussions with them for a specific clinical trial. There's huge pushback on using composite biomarkers. I mean, I think we have to look at the SOD1 story, don't we, in neurofilament as a secondary outcome measure. That's a great story. So I would say, my advice to anyone now is, you got to do the primary outcome measure that you're going to be made do. Now, we don't like some of the primary outcome measures we're being made do by the regulators, and this is why I need to be careful what I say. But I would say make sure you've got the right biomarkers as secondary, because we know there's a pathway that if it does well enough as a secondary, it can get you where you want to be.
Hi. I was really excited by the MRI data you showed because it reminded me of some of the histology we see in a rat model of CMT. And I was wondering, do you think there's enough data already from humans with MRIs for which there are animal models for which we have histology that we could train deep learning models to predict the human age and outcome and progression from the animal histology so that we can get histopathology, sorry.
So, I'm going to say the obvious thing. Mice and rats are not men and women. So I think there is a problem always. I mean, I know they're great, but they're, when you look at the size of them compared to the size of a human, I think that, it'll always be the surrogate in some ways. The non-human primates, of course, are great, but we don't have models from those. We have some dog spontaneous models of quite a number of our CMTs, but again, they won't do it. So that's my concern. I think the fat fraction data is very tight now. It is also found in muscle diseases. It's just different patterns. But again, if you damage muscle, that's what happens to muscle, regardless of the damage. And in Duchenne's, that are non-ambulatory, they've developed it in the arms. It's more difficult in the arms because you have to stabilize them. In FSH, and it may be in TRPV4, you might have to look at whole body to allow for the upper and lower limb. So I think it is an area that's moving quite fast, but I don't think comparing it back down to the animal models will make that much difference.
Okay.
Hi there. My name is Andrew with Alexion or AstraZeneca. Have you taken a look at the Olink proteomic data from the UK Biobank to maybe identify some, serum biomarkers for some of these CMT subsets?
I'm sorry, I didn't get the question.
Have you been able to take a look at the serum proteomic data from Olink and the UK Biobank to maybe identify some biomarkers for CMT?
No, we have ongoing studies using the UK Biobank data, but no, we haven't looked at that. There is some CMT patients in it, but not a huge number of them. There have been, proteomic studies done. There's a very nice one done, the TTR amyloid nerves and in some CMT nerves, and John Spavern has done quite a lot of it yet. But the best ones that have come out, I've shown, but I'm sure there are other ones I don't know about or haven't been published or haven't been presented yet.
Hi, Mary, over here.
Hi.
Paul August from Revere Therapeutics. One of the considerations, in terms of thinking what's happening in patients during clinical trials is how the patient feels. And I didn't see or hear you say anything about patient-reported outcomes. What's your feeling on that as a measurement for secondary or exploratory endpoints?
So, I mean, I was up there. I didn't comment on specifically. You're absolutely correct. So the CMT, patient-reported outcome measures are extremely important. And the CMT-HI is one that has been developed from CMT. Now, I have to say, first of all, as a primary outcome measure, it's difficult with regulators. They really want a lot of data for that. My feeling is this from looking after lots of patients, that they're very important as outcome measures, but they're unlikely to be sensitive over a very short period of time. Often when you do quality of life in CMT patients, it can be quite good because they've got used to it over a long time. So it is difficult, but there's no question the patient-related outcome measures are extremely important, and the follow-up of those will be very important. So there's a whole part of this is through the Inherited Neuropathy Consortium. There's adults assisted with CMT-HI, there's pediatric, there's parents for children, proxy ones, all of that will be very important. And I would say obviously has to be involved in clinical trials as a secondary outcome measure. It may be that it's a primary outcome measure in certain clinical trials. I would always worry about a patient-reported outcome measure as a primary outcome measure in a 1 or 2 year trial. I just feel it probably will mask something or maybe showing something else we don't know about. I mean, one of the things about these genes is they're ubiquitously expressed in the proteins, and, we don't know, well, why are patients so fatigued? It's more than just the muscle weakness. So we don't understand. And there may be reasons people could feel better. It doesn't mean the drug is working, but may not be what we think it's telling us. So I think understanding what a patient-related outcome measure is telling us is actually quite challenging until we understand the diseases better. But of course, I wouldn't want to say in any way that patient-reported outcome measures aren't extremely important.
Okay, great. Thank you so much, Mary.